Thank you, thank you. Okay, well, I'm pleased to be able to greet some of you for the first time. Others got to meet me yesterday morning. The Greencoats donate money to a fund to allow them to do something special with each meeting. The ACOG Connections were one of our projects, but one of the things we decided this time was to help sponsor a special talk, last-minute edition, on the Zika virus. Now, I have two things about the Zika virus that are keep me up at night. One is that my daughter-in-law, who is due in September, lives in Birmingham, Alabama, which is not quite ground zero, but close. So I'm a little worried about my grandchild. The other is I went through the Ebola crisis, which didn't materialize, although we did have at least one case that made the national news that turned out not to be a case, where I learned to don and doff all the Ebola gear and all of that, and there were signs everywhere. And with this, you're not seeing the signs. We're not quite sure what to do, all of this. And I think for those of us who are in the trenches with obstetrical patients, particularly in areas of concern or where people have traveled to areas of concern, many of us are feeling like we're not quite sure what to do. So for that reason, we've asked two experts, as best you can be an expert on the Zika virus at this point in the evolution, to come and give us some guidance or some background. One is Dr. Denise Jamieson. She is chief at the Women's Health and Fertility Branch at the CDC. She's a captain in the United States Public Health Service and an adjunct professor at the Department of Ob-Gyn at Emory, where I want to make a point of saying she is still very clinically active and is still providing care to Ob-Gyn patients. So she is in the trenches. The other is Dr. Laura Riley, who many of you already know. She's at Boston Mass General, where she is an associate professor, and she is the vice chair of the obstetrical service there. And more interesting, she is not only MFM trained, but she also has a fellowship in infectious disease, with great interest, obviously, on those that complicate pregnancy, such as HIV and now the Zika virus. So with that, I'll have Dr. Riley and Dr. Jamieson come up, and they'll kind of explain how they're going to do this session. But there will be opportunities for the audience to ask questions. If you do ask a question, please go. I believe there's a couple mics, and please use those so we can hear the question.
Good afternoon, everybody. So it's my pleasure to sort of co-present this update on Zika virus. And I thought we would do something a little bit different. Dr. Jamieson really is the expert. I'm not. I'm a wannabe. Dr. Jamieson is going to give a really nice overview of sort of what we know about this virus and its implications for pregnancy. And then when she's sort of completed that, we've created a few cases. Actually, unfortunately, they're real cases in our institution to sort of walk through how we've been counseling patients. And we also want at that point for it to be quite interactive, so people can feel free to move forward, and then obviously any of the physicians out there who I know are actually doing this really hard work, if they can also participate, we'll all learn lots. Thank you.
Good morning, or afternoon, I guess. Thanks for the opportunity to talk about Zika. This is a rapidly evolving situation. So what is Zika virus? Zika virus is a single-stranded RNA virus. It's a flavivirus. It's very closely related to dengue, yellow fever, Japanese encephalitis, and West Nile virus, and it's transmitted to humans primarily by the bite of an Aedes mosquito species. And we see on the top slide here the Aedes aegypti, which is the most efficient vector, as well as the Aedes albopictus, which is spread more widely in the United States and can also transmit Zika. Zika was first isolated from a monkey in Uganda in 1947, but prior to 2007, there were only sporadic cases of human disease reported from Africa and Southeast Asia. In 2007, we had the first outbreak reported on Yap Island in Micronesia, and then in 2013, greater than 28,000 suspected cases were reported from French Polynesia. So where is Zika now? This is posted on our CDC website. There are currently 37 countries and territories in the Americas and 56 countries worldwide reporting active Zika virus transmission. In the United States, current transmission is occurring in Puerto Rico, American Samoa, and U.S. Virgin Islands. However, you'll see many states in the U.S. have had cases of Zika that have been travel-associated, and those are shown in green. Where's the mosquito that transmits Zika? Well, on the left-hand side, you see the Aedes aegypti mosquito, which is primarily in the southern states, and then the Aedes albopictus, which has wider spread in the United States. How can Zika virus be transmitted? It can be transmitted intrauterine, it can be transmitted perinatally, sexual transmission has been reported, and a case of laboratory exposure has also been reported as a mode of transmission. There are other modes of transmission where it's theoretically possible but have not been documented, and that's blood transfusion, organ or tissue transplantation, breast milk, or potentially fertility treatment. What does Zika look like clinically? Well, it's generally a mild disease. The vast majority of people with Zika either have no symptoms or mild symptoms. Symptoms last typically several days to a week. Severe disease is possible. Fatalities are rare. The most common symptoms are fever, rash, arthralgia, conjunctivitis, myalgia, headache. And we think that once a person has been infected, he or she is protected from future infections. In terms of clinical management, there's no vaccine, there's no specific antiviral treatment, and so basically it's supportive treatment. You treat the symptoms. You want to avoid aspirin and other nonsteroidal anti-inflammatory drugs until dengue can be ruled out. Now let's turn and talk a little bit about Zika in pregnancy, what we know and what we don't know. We know that pregnant women can be infected through the bite of an infected mosquito, and we know women can be infected through sex with an infected male partner. If infected around the time of conception, we believe that Zika may present risk to the fetus, although we still don't know for sure. If infected during pregnancy, we know that Zika can be passed to the fetus during pregnancy or around the time of birth. Based on quite limited information, we do not have any evidence that pregnant women are more susceptible to Zika. We know that infection can occur in any trimester. We do not know the incidence of Zika virus infection. And there's no evidence of more severe disease compared with non-pregnant women. Zika virus has been identified in various tissues, amniotic fluid, placenta, brain, and products of conception. This is an image from a CDC lab of magnified brain tissue. We also know there's been a lot of focus on microcephaly, but this is not limited to microcephaly. There are a variety of brain abnormalities associated with congenital Zika virus infection, and the list is growing. Just to give you an example, the CT on the bottom of a typical newborn head as compared to images from a newborn born with Zika virus infection, and you can see some of the findings from the last slide on here. To give you a better idea of what this looks like clinically, you see the infant born. The Zika virus seems to have a predilection for neural tissue. It destroys the brain tissue. It damages the brain tissue. The brain shrinks. You can see the skull, how the skull collapses, and it leaves rugae on the scalp of where the skull has collapsed. These are images from Brazil. Another common question is, how often does this happen? How often are fetuses affected when their mother is infected? And the bottom line is we don't know. Right now we have a very large range of estimates, ranging anywhere from about 1 to 30%. So in a study from Brazil, 42 women with laboratory-confirmed Zika virus infection on ultrasound had 29% had abnormalities, 17% had structural brain anomalies. At the time of publication in New England Journal, most of these women were still pregnant, so we'll have to wait and see how many of them have abnormalities at birth. Sort of the lower end of the spectrum is from French Polynesia, where 8 cases of microcephaly were identified. These were identified retrospectively. So early on, people said, well, why are we seeing this in Brazil? And we haven't seen this in other places where Zika virus, where there have been outbreaks of Zika virus, most notably French Polynesia. And when and the bottom line is that if you're not looking for it, microcephaly is still a relatively rare outcome. And if you don't have birth defect surveillance set up, you may not find it until you look carefully. And so when they went back and looked carefully, they did find an increased incidence of microcephaly attributed to Zika virus infection. And using what they knew about how many cases of microcephaly occurred during an active Zika virus outbreak, they estimated that there was about a 1% risk of microcephaly. This is a report of a U.S. traveler that was reported in New England Journal of a pregnant woman who had symptom onset at 12 weeks gestation. She had abnormalities found on a prenatal ultrasound, follow-up fetal MRI, and post-mortem high levels of Zika virus were identified. So we've been thinking about this. I started on the Zika virus response at the CDC at the beginning of January, and we had been thinking about when it was the right time to say that we were confident that Zika causes microcephaly. And I held out for a long time hoping and thinking that, perhaps something else could explain what we were seeing. But at a certain point, we felt like there was enough evidence from a number of different emerging lines of evidence that we needed to say conclusively that Zika causes microcephaly. So on April 13th, we published a report that basically reviewed the evidence and felt comfortable saying that Zika causes microcephaly and other brain anomalies. So now that we know that Zika causes microcephaly and other brain anomalies, what do we do in terms of prevention? Well, for pregnant women who are not residing in areas of local Zika virus transmission, they should not travel to these areas. If she has to travel, she should talk with her health care provider, and it's really important to avoid mosquito bites during the trip. In terms of men who've traveled to an area, if they have a pregnant partner, they should either use condoms or not have sex during the pregnancy, since we know Zika can be sexually transmitted. So if a pregnant woman is in an area of ongoing Zika virus transmission, what can she do? She should prevent mosquito bites. She should use insect repellent. Any of the EPA-registered insect repellents are safe in pregnancy if used as directed. She should cover her skin by wearing long-sleeve shirts and long pants. In areas where there's not permethrin resistance, it's also a good idea to treat clothing with permethrin. It's important to mosquito-proof houses and to stay and sleep in areas that are either screened in or air-conditioned, and to eliminate standing water. In terms of sexual transmission during pregnancy, it's important to either use a condom or abstain. What about pregnancy planning and access to contraception? I've worked in the field of contraception for many years, and I think the Zika virus outbreak really highlights the importance of preventing unintended pregnancy. And I just wanted to point out that Dr. Nabal Bracero, professor in the Department of OB-GYN at University of Puerto Rico and the chair of the Puerto Rico section of ACOG, is here in the audience, and he's really been a pioneer in helping us think through these issues and working with our team on these issues in Puerto Rico. We understand that this is really a primary prevention strategy. We don't have a whole lot that works very well to prevent Zika at this point, but we know how to prevent unintended pregnancies. And so this is an important component of the work that we are doing. What are CDC current guidelines in these areas? These are the guidelines that are posted on the web for women who travel to these areas but do not live in areas of ongoing Zika virus transmission. If women have signs or symptoms of Zika virus, they should be tested. Serologic testing can also be offered to asymptomatic women with either a history of travel to an area with active Zika virus transmission or who have sex without a condom with a symptomatic male. A negative IgM test within 2 to 12 weeks approximately after exposure could suggest recent infection did not occur. And for pregnant women with possible exposure periconceptionally, they can also be offered serologic testing within 2 to 12 weeks of exposure. The guidance for women living in endemic areas where there is ongoing transmission of Zika virus disease, the guidelines are slightly different, and they're, again, posted on our website. Again, if a woman is symptomatic, she should be tested. If the woman does not have symptoms, we are recommending that she be tested twice, once upon initiation of prenatal care and once in the mid-second trimester. And again, pregnant women with male partners should use condoms or abstain for the duration of pregnancy. A big issue has been diagnostic testing. No one really paid much attention to Zika virus, particularly, and no one paid attention to most arboviral diseases, really, in the United States. And so the diagnostic testing has really lagged behind. We don't have a commercially available test. The test performance of these tests has not been carefully worked out, and this is a real need. And through emergency use authorization, CDC is working to expand laboratory diagnostic testing, and healthcare providers, as many of you know, need to work through their state health departments to facilitate diagnostic testing. But this is not a test you can just check off on your Quest form and send to the lab. And this has been, I think, one of the biggest challenges. Recently, CDC also published some guidance around urine testing. There's some limited evidence that virus may persist in the urine longer than in the blood, and so it is reasonable to send urine tests along with blood tests for Zika virus PCR. This is our guidance regarding when it's safe to conceive. So for travelers, we recommend that women wait 8 weeks after either symptom onset or after exposure. For men, it's slightly different. If a man has had Zika virus disease, we recommend 6 months after symptom onset, and this is because we know the virus persists longer in the semen. And for residents living in areas of local ongoing Zika virus transmission, it's a difficult situation to figure out how to counsel regarding pregnancy. Planning your pregnancy and having a baby is a very complex, very personal decision, and it has to be, preconception counseling has to be in the context of many factors, including the risk of Zika. As all of you know, there are many factors that may aid in decision-making, and it's, again, a very complicated decision about when to conceive, knowing the risks and what we know about Zika virus. We have a clinical tool posted on the website that helps clinicians counsel their patients who are living in areas of ongoing Zika virus transmission. In terms of clinical management for those women who are infected with Zika virus, antepartum, we recommend serial ultrasounds. You may consider amniocentesis as an additional piece of information, and we recommend referral to a maternal fetal medicine specialist. Postpartum, we're asking that people collect specimens and test the infant in order to get as complete a picture as possible about the long-term effects of Zika. So what are we doing to respond at CDC? What does a response at CDC look like? Well, there are 3 levels of activation of our Emergency Operations Center. And the Emergency Operations Center is that place you often see Sanjay Gupta and others on CNN talking from, where there are lots of computer screens and lots of people working busily. There are 3 levels of response. There's level 3, which is the lowest level of response. There's level 2 and level 1. And we very quickly went from level 3 to level 1, and we are transitioned to a level 1 response, which is the highest level of response, on February 8th. Prior to Zika, there have only been 3 other level 1 activations. One was for Hurricane Katrina, pandemic flu, and Ebola. We are setting up registries, surveillance systems in various places. We have the U.S. Zika Pregnancy Registry, which right now is primarily for pregnant women who have traveled or who have partners who have traveled. We have the Zika Active Pregnancy Surveillance System, or ZAPS, that's active in Puerto Rico, and this is very similar to the overall U.S. Zika Pregnancy Registry, but it's specifically tailored for Puerto Rico since they've been the hardest hit part of the United States. We also have a surveillance system in Colombia. We're working closely with the Ministry of Health there and are doing retrospective and prospective surveillance there. In terms of the U.S. Zika Pregnancy Registry, the purpose is to monitor pregnancy and infant outcomes following infection during pregnancy, and we are using this information on an ongoing basis to inform clinical guidance and public health response. It is a supplemental surveillance effort coordinated by CDC, and it's really dependent on all of you. It's dependent upon the collaboration of state, tribal, local, and territorial health departments working closely with clinicians in the states and territories. Any woman with possible laboratory evidence of Zika virus infection is included in the registry, and we really need all of you to help support the registry. Please spread the word about the U.S. Zika Pregnancy Registry, and please assist the health department with follow-up for those patients of yours with Zika virus infection. What else are we doing? We are providing updated clinical guidelines. Early on in the response, our pregnancy guidelines changed 3 months in very rapid succession, and this is because we are literally learning more every day about Zika virus infection. We share up-to-date information on the website, and I also wanted to mention we do have a clinical inquiries line that functions 24/7. You can talk to a subject matter expert. Most of the subject matter experts are obstetrician gynecologists, and the way to reach that line is to call the CDC Emergency Operations Center watch desk and ask for the Zika pregnancy hotline or email. As I mentioned before, we are working closely with partners in Puerto Rico to improve access to contraception. As I mentioned, of the U.S. states and territories, Puerto Rico has reported the most cases of Zika virus infection. We published an MMWR article estimating the amount of contraception we would need to ensure access for all women of reproductive age in Puerto Rico. And in collaboration with the Puerto Rican Department of Health and other partners, including ACOG, we're exploring how to establish a network of trained OB-GYN and other physicians and clinics to provide increased access to contraception. We also have tools, as I mentioned, on our website that are updated regularly to assist healthcare providers. I just want to say that although we are literally learning more about Zika every day, there is still far too much that we don't know. We don't know what the full range of potential health problems that Zika virus infection may cause. We don't know the level of risk from Zika virus infection during pregnancy. We don't know when during pregnancy Zika virus infection poses the highest risk to the fetus. And we don't know if there are other factors that might affect the risk for birth defects. Unfortunately, we are currently in the midst of historic times, As our CDC director, Dr. Tom Frieden, said, never before in history has there been a situation where a bite from a mosquito could result in a devastating malformation. I've been an OBGYN working at the CDC for 20 years. During that time, I've worked on many other responses. I've worked on pandemic influenza. I worked on Ebola. I've worked on many other infectious disease outbreaks. And this response to Zika is by far the most complicated, the most challenging, and the most frightening. We need to know more, we need to act quickly, and we desperately need a vaccine. Thank you.
So we will do a few cases, and then I suspect that that will spur even more questions from the audience. So if we can get the next presentation up of cases, that would be great. Okay. So we have a 37-year-old woman who is in her first pregnancy at about 25 weeks gestation. She's got a sure LMP, so you know you have the dates. 2 weeks prior to her conception, through week 10, she traveled to multiple places, Bolivia, Ecuador, and Colombia. She reported having many bites, but did not have any of those symptoms that Denise just spoke of: no fever, no rash, no conjunctivitis, and no joint pains. On 2/18/16, she had a fetal survey, which was normal, and given the new CDC guidelines, and as you may or may not recall, the guidelines changed from no testing, just do ultrasound, to now you should do the test. So we were frantically calling people back into the office. I'm sure everybody was in the same situation as we were. She came in and she had the serum test for Zika virus, so she had the IgM, which was what was available to us. And on 3/30, her Zika virus test, IgM test, came back and it was positive. And on 4/1, she had a repeat ultrasound, which was normal. And I might just say that, as was told to you before, I'm in Massachusetts, and at the time, Massachusetts was not doing the IgM test, so the test was being sent from the Department of Health in Massachusetts to the CDC, and ultimately, I guess, to the lab at Fort Collins in Colorado, which was not a clinical lab, but a research lab. So I think, the issue here is that we have someone with a clear exposure, and so, what needed to be the conversation at this point? And so I just sort of threw up some of the things that we felt were important to talk with the patient about. Obviously, at the time, and now we can say, we've actually declared that there is a clear association. In fact, there's a cause from Zika virus to microcephaly, as well as other neurologic abnormalities. We also did discuss reported cases in the literature concerning the timing of infection and poor neonatal outcomes. But as Denise just mentioned, it appears that the sort of worst possible timing isn't really known, right? It could be at any point, the infection can happen at any point during pregnancy, and it looks like there's a range of outcomes that have been seen, including in the New England Journal. There were a few cases where women were reported to be infected even late in pregnancy, and some of those outcomes were stillbirth. So I think there's still lots to be learned there. This became a lot of conversation whether or not we should offer this patient an amniocentesis, because really all the information that we had was that this woman obviously had Zika virus infection, but whether or not her baby was infected, and then honestly what the patient really cares about is her baby affected. And to reiterate Denise's prior points, it looks like the likelihood of the baby being affected would be somewhere between 1 and 29%. Is that fairly what we're telling patients? Do you want to add a little bit more there?
Yeah, I think it's really hard because we don't know. We think the time of highest risk is the first trimester and early second trimester. We don't have a lot of information, for example, about periconceptional risk or exactly if there are certain periods that are more risky than others. And I agree that amniocentesis, although it has not been well validated in Zika, we use it in other viral diseases, and it's one more piece of information that may or may not be helpful to the pregnant woman and her partner.
And then the other issues, obviously, I mean, this lady in Massachusetts, you can't terminate pregnancy after 25 weeks, after 24 weeks gestation. So the conversation about pregnancy termination wasn't necessarily germane, although many of you know there are other places where she could have gone to get a late termination. So I think that, you know, the options are limited, and I think that that's one of the other scary things about this disease is that making the diagnosis of some of these neurologic abnormalities, those are things that may be made later, far later in pregnancy than you want the information. So, you know, if you could ideally say we'd know at 20 weeks whether or not you were infected at 12 weeks, that would be terrific, but we can't say that, which leads us to these serial ultrasounds and potentially not being able to offer pregnancy termination. I wonder if there are other questions that may have been brought up by that case. And please, we have colleagues here from Puerto Rico, from Brazil, and other places who are really dealing with this 24/7. And so we are happy to have you come and share your expertise.
Hey, thank you for your great presentation so far. One question I've got, because we're seeing these patients, of course, in North Carolina as well. When can you quit doing your serial scans?
Good luck on that one.
So,
I didn't mean to ask such a simple question.
no, it's, we don't know. I mean, you know, we're recommending ultrasounds, that you consider ultrasounds every 3 to 4 weeks. I mean, if the testing's negative and it was done in the correct window, then I don't think you need serial ultrasounds. The woman is infected. You know, past a certain point, there aren't a lot of interventions, but most women want to know, and most women will be followed every 3 to 4 weeks to find out, you know, if there are effects detected on ultrasound. I don't know what you're doing, Laura.
Yeah, so you know, we're doing, if the woman has a positive, has a test that shows that she definitely is infected, then we're continuing to do those serial ultrasounds. I think the harder question is, which is going to come up here, is if you're negative, if your, you know, index of suspicion is high and then your testing is negative, what the guidance would say is that you've gotten an ultrasound that was negative, her testing is negative, you can put her back into usual prenatal care, which would mean, I'm assuming, not serial ultrasounds. And that's been a little bit harder for us to actually put into reality as patients remain very nervous, no matter what you tell them. And as Denise alluded to, I think, you know, unlike other viral illnesses where we clearly know when the IgG goes up in relationship to infection or exposure, and when the IgM goes up, and we know when it comes down, and you can easily look at that graph and figure out, oh, gee, I drew her blood at the tail end, and so maybe it's negative and really it's positive. So we don't have that graph per se for this disease, so I think that that's another sort of challenging scenario. So I think the other thing that never actually comes up with this is, ooh, this is a costly disease, even for those who don't have it.
And in terms of, you know, early on, we were hoping that asymptomatic women would not have, their fetuses would not be affected. And I think we have growing evidence that we're concerned about asymptomatic as well as symptomatic infection. Early on, we were not recommending testing for asymptomatic women, and the guidelines were revised. The testing of women, asymptomatic women, is complicated. And so I think the message is more testing around the time of symptoms, and to be very careful about, particularly for women who live in areas of ongoing Zika virus transmission, to do more testing of women who may have symptoms. You know, early on we were very There was a lot of sort of old literature about how 80% of persons infected with Zika are asymptomatic. That's not entirely correct. The bottom line is that it's mild disease, so especially in endemic areas where you may have dengue and other febrile rash illnesses, it may not be recognized. So probably it's correct that the vast majority of infections, people either have mild symptoms or no symptoms, but I think it's critically important that if a woman has symptoms to do PCR testing as soon as possible. And now it looks like we should be testing blood as well as urine to try and pick up the virus, because once you get into the period of, depending on serology, IgM testing, there is no reliable IgG test. It becomes much more difficult to sort out due to cross-reactivity with other flaviviruses.
Should we, don't move. I'm going to go on to the next case because it may bring up some of these other points. So the next case is a 32-year-old woman who's about 30 weeks gestation, totally uncomplicated medical and surgical history. She had a clear exposure at 11 weeks in Puerto Rico. She reported again many bites, no symptoms. And so we all now know what that means. And her IgM was sent, and it returned in early April, and it was negative. She had an anatomic survey at 18 weeks, completely normal. She had follow-up ultrasounds, and here you could see sort of how we are trapped in what we're trapped in. She had follow-up ultrasounds at 22 weeks and then 26 weeks, which were essentially normal. And at 30 weeks gestation, on her now fourth ultrasound, it showed that she had borderline ventriculomegaly on the right and moderate ventriculomegaly on the left. And the head circumference, though, was 58th percentile for the gestational age. There was no other pathology noted. And you can imagine people were looking for anything and everything. She did have an MRI, which confirmed only unilateral ventriculomegaly, which was 14 millimeters. So I think in this situation, people are thinking to themselves, oh my God, this lady got 4 ultrasounds. But herein lies the problem, is it's really hard to extract patients out of that every 4-week ultrasounding. And I think part of it was driven by the fact that many of us are having trouble getting the labs back in a timely manner. So we send the IgM off and it doesn't come back for 6 weeks or 7 weeks. The patient's already had 2 ultrasounds in that period of time. So I think that that's just the reality. And I was going to ask Dr. Jameson if we see anything on the horizon that might shorten that time frame, and what else is out there.
In terms of lab capacity, CDC has been working primarily with state labs and some commercial labs to increase their capacity for both PCR testing as well as serologic testing. I think we have a long way to go. There are many commercial companies that are working on better, faster diagnostic tests. But we'll just have to wait and see how many resources are put into some of those tests and how they're marketed and how quickly we can get them online. But right now there's no commercially available testing for Zika, and it really impedes our efforts to be able to provide really important, critical information to pregnant women.
I'm just going to make one point, and then we can ask the audience for questions. So the differential diagnosis, obviously, for ventriculomegaly is really quite vast, and I just put it out as a plug that we don't want to forget, as many of us are basically Zika virus-centric these days, as are the patients, that there are other, obstetric infections that we need to consider in the differential, and don't just take the time to do the amniocentesis and not investigate those other things. Ultimately, my partners called me to let me know her Zika came back negative, her CMV, toxo, and the aneuploidy screen is negative. So, we will find out when this baby is born. But I just put out that plug because I think that, obviously it's the thing that's on everybody's minds, but we don't want to forget everything else. So maybe we can take some questions and we can go in this direction. Did you want to start over here? Yeah?
I just wondered, especially with that first case, and you again mentioned amniocentesis, if there's any evidence that amnio might increase the risk of either infecting or affecting the infant.
Yeah, we thought a lot about, so no, there's no evidence. We have very, very limited evidence of the performance of amniocentesis in pregnancy. In the second guidance document, it was included in the algorithm. In the third guidance document, the most recent, it's a consideration, but we actually took it out of the algorithm. It's information that women often want to know and their providers often want to know. We do it for other viral diseases. You know, early on in HIV, we thought it increased the risk. It looks less risky than we had once thought in terms of increasing the risk of transmission. I think we don't know. If it's an important piece of information and it's going to change your clinical management, then it may be a reasonable thing to do.
Hi, me?
How about in the middle? Yeah.
Hi, I just had a question about travel to Mexico. I practice in South Texas, and my colleagues all told me to come up here to this meeting and figure out what we're supposed to do, because the vast majority of our patients have been to Mexico or have a spouse that's been to Mexico, you know, in the 6 months prior to conception. So does that mean that all of them need to get tested?
We thought
That's
a lot.
A huge number.
We've thought a lot about border health, and we do have some guidance posted on the website specifically about border health, people who maybe live on one side of the border and go back and forth. There hasn't been a lot of Zika along the border states yet, but I think it's a difficult question. For endemic areas that do have local transmission, we recommend, testing twice during pregnancy, but it's really based on the determination of your health officials. It's in conjunction with what's your laboratory capacity, because that's very limited, and what's the likelihood of transmission based on how much Zika is really being transmitted in your area. So depending specifically on where you are, you could consider routine testing for women who have traveled to Mexico during the critical time periods. But again, it really depends. It really depends. I mean, there's not a great distinction between the line between Mexico and the United States.
Yeah, okay. Thanks.
I'm getting back to the amniocentesis question, because amniocentesis isn't without risk. So would it change your treatment plan, or is this just information we'd like to know? If it's negative, do we do anything differently? If it is positive, do we do anything differently?
I mean, I don't know if you can comment. Anecdotally, in some cases, it has helped women make decisions about their pregnancy. So I think it just depends on the clinical scenario. I don't know if you want to comment, Laura.
I think it's part of the conversation with the patient, obviously discussing the risks of amniocentesis, but also what are you going to do with the information. I do think, though, I mean, at least in the conversation, we've only had one, thankfully, conversation about this, and the patient was very clear that if it came back and there was Zika virus in the amniotic fluid, she wanted a pregnancy termination. So for her, it was going to make her do something different. But we all have had that experience with any other thing that you do an amnio for, right? People say one thing, then you give them the result, and they tell you they do something different with it.
And we don't have any data to say if it's positive, there's a X% chance your baby's got a problem. We got nothing. We got nothing. Okay.
We got nothing. But you know what? We got nothing with some other viruses, right? So doing an amniocentesis for varicella, you find out that there's varicella in the fluid, doesn't necessarily mean the baby's affected. But, that's sometimes a very nuanced conversation with patients. Oh, I'm sorry. Yes, we're going this way.
I'm from St. Croix in the U.S. Virgin Islands. We have about 14 cases. They're all vector transmitted. But I just wanted to give you a point of information. It recommended that all our pregnant women be screened. We had not yet had a formal recommendation for rescreening, but initially they told us even though everyone would be screened, we figured we would get results back very quickly. In some cases now, they said that they had 1 million tubes waiting to be tested at the CDC, because that's where our health department sends them. And so I just wanted to make sure that you knew that. They were going to prioritize that only pregnant women who were symptomatic would be moved to the front of the line. So I'm not sure if you're aware. And then, so my real question is there any other quicker way to get screening? And are you aware if LabCorp or Quest or any of the big national labs will do testing for either blood and, now you tell us, urine?
Yeah, thanks for your comments. And I can assure you that there aren't 1 million samples waiting at Fort Collins to be tested, but I do agree that there have been unacceptable delays in testing. And again, this was a virus that the incident manager at the CDC, Lyle Peterson, has been working on arboviral diseases for decades. And he has a quote that basically nobody cares about arboviruses until it's too late. And I think Zika is a perfect example. This was a neglected disease, sporadic, very, very small outbreaks, no widespread outbreaks, and all of a sudden it's got this terrible link to devastating birth defects. So I think you're right. We need much more lab capacity. It needs to be built up. CDC has been working with state health departments, local health departments, and commercial entities to try and amp up testing, but it is not where it should be. You're exactly right. We need more testing, and we need to ensure that pregnant women, the testing of pregnant women is the very highest priority. And we are working towards that, but I think there are huge gaps.
And Thursday, I got a notice from the health department that one of my patients has an equivocal lab result. Can you explain what that means?
Yes, the serologic testing is very complicated, and unfortunately Zika is cross-reactive with dengue and other flaviviruses. And in areas of the world where dengue is endemic, it can be very, very hard to sort out whether an antibody response is to Zika or whether it's to dengue. So you first do IgM testing for both Zika and dengue, and then you have to do plaque reduction neutralizing tests or neutralizing tests to try and sort out whether the antibody response you're seeing is really due to Zika, likely due to Zika or dengue. And those algorithms that you have to grow virus, and so that testing, that follow-up confirmatory testing takes a long time, and it is not readily available. There are only a few places that can do it. So in areas where dengue and other flaviviruses are endemic, it can be very hard to sort out. So in the Zika, U.S. Zika pregnancy registry, we are following, and in Puerto Rico, we're following some women who we know have confirmed laboratory evidence of Zika, and another group of women who have evidence of flavivirus that's possible Zika virus infection that may have Zika and may have another related flavivirus.
So just to follow up on that, so that patient that you had that was equivocal or inconclusive is what the results that we're getting back. Those people are in the algorithm for essentially being infected. So they should be getting serial ultrasounds, and they should be in the registry, and you should, at the time of delivery, be sure to send the placenta, the cord blood. I don't remember the long list, but we should do the whole thing for those patients because you don't know whether or not it's Zika or dengue.
Yep.
Yes. Dr. Riley, Dr. Bracero from Puerto Rico. I wanted to say thank you publicly, Dr. Jamieson, to CDC and to ACOG for all the work that you're putting in Puerto Rico. I mean, the meaning of boots on the ground is what you're doing right now in Puerto Rico. So thank you for all of that. Second, Dr. Riley, we were commenting on this before. The first adverse fetal outcome case that we had, it was a patient which actually tested negative for IgM, and it goes to highlight the importance of that critical time window on when you test. It's important to know that you're testing within that 7 days, which test you're ordering or you're looking into, but also knowing that the 12-week at the end of the detection of IgM is also important. And for us as clinicians, not to lose perspective on the importance of ultrasonography. I mean, sonography is going to be in our tool kit always, and we gotta use it. We gotta master it. We gotta get really, really good at picking up these findings as we go along fighting this battle. And finally, we gotta look also into the history of Zika. If we look into the first 1952 Uganda paper, the virus was actually injected into the abdominal cavity and the brain of mice and monkeys. So we got to go back, and although those are all papers, we got to look at them and see how those animals behaved. In Puerto Rico, we have an excellent rhesus monkey colony, and we're all for helping CDC finding out answers in that fashion. Thank you.
Thank you very much for your comments and ongoing support.
We know that the brain isn't fully developed at the time of birth. What happens if we cut the cord? What happens to an infant, a newborn, who gets direct exposure to a mosquito bite, and what's the risk to a CNS sequela, manifestations related to this? Everything's been about maternal passage. What about direct passage to a child?
It's one of the issues we're looking into now. We know that there are neurologic sequelae of Zika, although not common in adults. We don't have much information about pediatric infection. I think now, at this point in the outbreak, when we know that there is a predilection for neural tissue, I think it's a concern, and it is something that we are starting to pay more attention to and follow infants who are infected and young children who are infected.
Thank you.
Question?
Yeah, so you had the nice map of all the places where the mosquito is in the southern United States, and I guess my question is, what's the estimation currently around the likelihood that this will become endemic throughout all that area? And then sort of the follow-on on that is, should that happen, I would think this would pretty much overwhelm our capacity to do this type of screening that we're recommending now, both on the lab side as well as the sono side.
So the Aedes aegypti, which is the most efficient transmitter of Zika, as I showed you, is largely spread throughout about a third of the United States. We're hoping that we expect that there will be some localized transmission. It is spread by the same vector as chikungunya, although chikungunya is not a flavivirus, but it's spread by the Aedes, and there was very limited transmission. So I think it's unlikely that we're going to go through the whole mosquito season without any cases of Zika local transmission. Hopefully it will not be widespread, and the best estimates from our arboviral experts is that it will not be widespread for a variety of reasons. And I think we are preparing, however, with local health departments, state health departments, we're preparing for various scenarios if these predictions end up not being correct.
I'm just going to jump to the last case because it sort of dovetails with what that gentleman's question was. So we're done with that. Okay, so this is a 38-year-old G0 woman who recently got married and is moving to Key West this summer. She currently has an IUD, thankfully, So I think that this is going to be the question that is coming to many of us right now is where do we go, what do we do? And so I think the first thing that we're going to need to do is assess this woman's intent concerning pregnancy, concerning conception, given her advanced maternal age. You're sort of stuck, right? You're not going to tell her to wait forever. And then I'm going to get to that question because I think that that's another question that comes up. Obviously, she needs to understand what the potential issues are if, in fact, she gets a Zika virus infection, and then also discussing the sexual transmission of Zika virus. And I think you probably mentioned it several times, or maybe we mentioned it earlier this morning. This virus has been found in the semen of men up to 62 days, and so clearly that exposure is a lot longer than even what has been seen in women. So that needs to be something that people think about. The only other thing I would say is that our plan for this patient, or what I've already done the consult, was to talk about personal safety issues surrounding DEET and the safety in pregnancy. I think if you don't tell that to pregnant women, they assume it's not safe. And then also sort of local mosquito control practices, trying to make sure that her housing is as good as it can be, and screens on the windows and all that kind of stuff, air conditioning. And then also just let her know that if in fact she does decide to go ahead and get pregnant, this is what that monitoring in pregnancy is going to look like. A lot of unknowns, a couple of tests, but a lot of unknowns. And so I think people sort of need to have the whole picture. One thing that I had asked Dr. Jamieson before, because people have asked me, 2 questions. One, should we tell patients not to go to Florida and Texas and Key West and wherever? I guess Key West is Florida, sorry. Should we tell people not to do that this summer, sort of based on this other gentleman's question? And then the second thing which I've heard, which to me makes no sense, but I have heard people say, should pregnant women just go to those places, get bitten, and then if what we think is they are then they are immune to it after that, they have lifelong immunity after that, then it's safe to go ahead and get pregnant. I guess my own pitch in that is I'm not sure why you'd want to trade getting bitten and potentially getting either West Nile or something else, which is not good in pregnancy either, or Guillain-Barré, which we didn't talk about because it's not necessarily pregnancy related, but I think it's important to say that there's other neurologic implications for Zika virus. So with that, what do you think?
Yeah, no, I would agree. First of all, we don't know for sure that it confers lifelong immunity. We think it does. But secondly, there are risks. Although it's generally a mild disease, it can be severe. There have been fatalities. And there are certainly neurologic sequelae, including increased risk of Guillain-Barré syndrome. So I would not recommend that a woman in anticipation of pregnancy try and get infected with Zika.
Question here in the middle?
Yes.
Avoid the question, should they travel? He said
should they travel?
Yeah, should they travel? Should we tell patients,
since there's not currently local transmission of Zika virus in the continental United States nor Hawaii, I think we are not recommending that they avoid those areas, just recommending those areas in the U.S. and elsewhere, which right now are the territories of Puerto Rico, American Samoa, and U.S. Virgin Islands. Avoid travel there if possible.
So I'll tell you what I tell my patients. I'm like, 1, get travel insurance. 2, check the CDC website right before you go so that you can change your mind if, in fact, they find local spread. Because I think that that's one thing that we are, in some senses, very lucky, is that the surveillance is in those places. And so hopefully, once it happens, we'll know. We'll know a lot sooner than people are traveling there. Question here in the middle.
Yes, I have 2 related questions. One is about the transmission rates of the Zika virus in comparison to the related dengue and West Nile. I mean, does it transmit faster or slower based on the experience? And if so, what would be the predicted incidence of the virus based on what we know about dengue and West Nile and other related viruses? And second question is regarding the testing. I know during there are developers that are working on this. I was in touch with one of them, Tulane University, and he's saying that just like during the Ebola crisis, their bottleneck now is getting samples to be able to improve their tests. So is there a way, I know during the Ebola crisis, getting the samples was actually the hardest part for the test developers, or being able to test their tests, in other words. And when I say samples, meaning positive and negative samples of the Ebola. I mean, obviously negative is easy, but positive samples of the Zika virus. So what are we doing to enable to get those samples, or are there sources of these samples that can be fast-tracked for these developers? I think this generally does make a statement about how unprepared we are for any kind of viral epidemic if we can't even get pregnant women to be tested with RT-PCR. So the question is, what is the current delay or time that a typical pregnant woman has to face before she gets her test result with RT-PCR?
So thanks for your questions. Regarding it's an interesting question about is our samples a bottleneck for development of tests. Very interesting because early on it was. Now we have enough samples. The biggest sort of bottleneck is just the development of this technology. So CDC is sharing what they have as widely as possible to as many states as possible, and trying to develop a network of folks who are able to test. Some states have very strong labs, some have less strong labs, also trying to share with commercial entities. But it just takes time to develop good diagnostics, and this is unfortunately a virus that no one much cared about prior to this large worldwide outbreak. In terms of testing delay, it varies tremendously depending on what state you are in or what territory you're in and who does your testing. As Laura mentioned, early on, the vast majority of testing was being done in a small research lab, CDC outpost lab in Fort Collins, Colorado, and there were very long delays. In some places, the delays have gotten much better. In some places, there are still unacceptably long delays. In terms of Zika transmission, my arboviral expert colleagues say that it's similar to chikungunya, and they use that as sort of a model for how we expect it to spread. Just want to mention that these mosquitoes are aggressive daytime biters, so they bite people in the house fairly aggressively and spread the disease fairly efficiently. So elimination of standing water around your house, use of screens and air conditioning, and other measures can make a difference.
So what is the prevalence of chikungunya then? I mean, is it an upper bound on what could happen? Like,
it was just sporadic transmission, so very low levels of transmission in the southern United States.
So we would expect the same with Zika then? Is that fair?
I'm sorry?
So it would be fair to expect a similar outcome with Zika? Is that?
That is what we are predicting. Not me, but other arboviral experts.
So we have time for one more question, actually, right here.
So in our hospital, we do cord blood collection for stem cell donation. For any woman that's been to a Zika virus-affected area during her pregnancy that maybe we don't have serology on, or someone who's tested positive on serology without necessarily the fetus being affected, would you say that we should not do cord blood collection in those patients?
Great question.
There's been a lot of focus on safety of the blood supply and testing the blood supply with highly sensitive viral tests. And it's interesting because I hadn't thought about cord blood. We thought about tissues, including reproductive tissues. But it's an interesting question. I had not thought about it until right now. But we need to think about it. Thank you.
Well, thank you, everybody. We appreciate that. I mean, this last question, I think, one last? Yeah, go ahead.
Thank you. I'm not a physician. I'm married to an OB-GYN, but I work in an outdoor sporting goods company, and I'm asked every day about the effectiveness of various insect repellents. And I have a question about your recommendation for DEET. It's my understanding, based on some reports done by, some testing done by Consumer Reports, reported in the July 2015 Consumer Reports, that picaridin is more effective in DEET in most cases, and that there is some information that some mosquitoes are becoming more DEET resistant. So do you recommend also other insect repellents besides DEET?
We are not differentiating, but there's not enough information to differentiate between the different types of insect repellents for these mosquitoes. We are recommending any of the EPA-registered insect repellents, and the most important factor seems to be using them properly and using them liberally. And luckily, unlike many other things in reproductive health, we actually have good evidence that these insect repellents are safe in pregnancy. So thank you for your question.
Thank you, everybody.
That's good, right?